Hello A&P1 students, this is Gina Piscatelli with your last skeletal system physiology lecture. If you remember last time with the skeletal system, we talked about how bones form through endochondral ossification as well as intramembranous ossification. And we also talked about how bones remodel continuously over an adult's lifetime. This time we're going to look specifically at some disorders, bone fractures, how they repair, a condition known as osteoporosis, and several types of arthritis. In addition, we will talk about how calcium homeostasis is maintained through activities of bone remodeling in particular. So I'll start with bone fractures, and there's different types of bone fractures. These types of bone fractures can be categorized based on the health of the bone and the amount of stress placed on the bone. So a stress fracture is an abnormal trauma that occurs to normal healthy bone. That's your typical kind of bone fracture when someone's in sports and they break a bone. It's typical. But there's also another kind of bone fracture. It's called a pathological fracture. And in this case, a normal trauma, and I hate to use the word trauma, but a normal activity, we'll say, causes a break because the bone was abnormally weakened through disease, and that has a lot to do with aging. It has a lot to do with hormone levels and how well the bone is remodeling with osteoblasts and osteoclasts. So this, for an example of a pathological fracture, think of someone not falling very far, but just kind of falling from a chair to the floor, and it might cause a hip fracture. That would normally be often, I should say, called a pathological fracture. There are lots of other ways to classify bone fractures or name them. You could name a fracture just simply by which bone is broken or where in the bone it's broken, so the location. Also, the position of the broken bones might be used to at least classify and partially name a bone fracture. For example, the broken bits might still be together, not displaced, so that healing would happen better. We'll look at what all these different things mean, but different ways to name a bone fracture based on position of the broken ends would be displaced or non-displaced. Is the bone completely broken or incomplete? What's the angle of the break? Was it oblique, at an angle, spiral, transverse? And whether the skin has been penetrated or not. So let's look at some examples. Here's an example of a epiphyseal fracture. So this fracture is being named by the location on a bone, and you can see that red arrow is pointing to the epiphyseal line or plate, depending on if we're in an adult or an adolescent. So that's where the fracture took place. Or you could name a fracture based on the bone that was broken. So here the humerus is broken, so it's a fracture of the humerus. One thing to note is that the epiphyseal line is a weak spot because it's still cartilage in growing children. Most of the time these fractures heal, but if they don't heal, you could get premature arrest of bone lengthening because the cartilage might ossify right away, and then you couldn't get any more length or growth in length. You need the chondrocytes in order for a bone to grow in length. Here are some other types of fractures based on, the names are based on the position of the broken bones. So in a displaced fracture, notice that the tibia, the two ends of the tibia that are broken have been fractured, are displaced, and the fibula probably too, right there. So there's at least one piece of a fracture out of alignment. And in a non-displaced fracture, like shown here, you've got the end of the humerus right here. The pieces of the fractured bone are still in alignment. I'm not even sure this is a complete fracture. It's hard to tell from just one angle, one x-ray. Now let's look at some examples of complete fractures versus incomplete fractures. So there are different subtypes of complete versus incomplete. So first let's look at an example of a complete fracture. So we've already seen one, and that was this one that we see, okay, that tibia is broken all the way across. Here we also have a complete fracture, but we have a different name for this. This is called a comminuted fracture because there's actually at least three pieces. So here's the end of one piece, here's the end of another piece, and you can see that there's a piece of bone right here. There might even be more. It's hard for me to tell, I'm not an expert, but that's called a comminuted fracture. Now incomplete fractures can be categorized too. They can be categorized as a hairline fracture or a green stick fracture. So a hairline fracture is definitely incomplete, and you can see that the fracture only goes across the bone a certain width of the bone. Everything is perfectly aligned, so you could say non-displaced, but the bone isn't completely fractured, and this healing will happen quite easily. Here's another example of what you would call an incomplete fracture. This picture shows an incomplete fracture, maybe a little bit more complete, and it's called a green stick fracture, and that's because the bone looks like it's bent. Okay, if you pulled a stick off of a young bush or a young tree, a branch, that branch would be green instead of, hard wood and bark. So it's bendable. That's where this gets its name. It's like a green stick. You can bend it and maybe one side will begin to fray, but the whole thing won't snap into two. That's where the name comes from. So this is an example of an incomplete fracture. This is common in children whose bones are still growing and are not completely hardened yet. And then besides using displaced or non-displaced as a way to categorize the position of the broken pieces of a bone, we can also use another factor, and that is whether or not the skin has been broken. So an open fracture is one in which the bone penetrates the skin, and I know it's really hard to tell right here, but this is definitely poking out of the skin. It could also be called a comminuted fracture because you see lots of pieces, not just two. A closed fracture is one in which the skin has not been broken. So again, this one looks like it's comminuted. There's many pieces. Okay, you've got lots of pieces there. And I wanted to mention that people don't often, at least in everyday language, use the term open and closed. They usually use this word compound. And I'm not sure where that originated from, but when someone says a compound fracture occurred, they usually mean that a bone has broken through the skin. And we saw one at the beginning of the slide presentation here, where the humerus is clearly, a piece of the humerus is sticking out of the arm. Ugh. I use diagrams instead of actual photos because I didn't want to freak you out, because they can be quite disturbing. Now let's talk about how fractures are healed. There's 4 main steps that occur. The first thing that happens is a blood clot forms, and that is because there are blood vessels in the bones, and the blood vessels have been broken or at least damaged to some degree, and that triggers the blood to form a clot so that you don't lose too much blood. We call this blood clot a hematoma, and it happens within a couple days. So the hematoma forms, and then a soft callus, an area of healing, is made, and it's composed of cartilage and a protein called collagen. Now this soft callus can't remain permanently. Instead, it needs to be replaced with a hard callus, and that's going to require mineralization or ossification with minerals, and so spongy bone is laid down. And this formation of the hard callus happens over quite a long period of time, depending on the degree of the break, of course. And the bone needs to remain in perfect alignment, and so it should be immobile during this time. It's still malleable when it's a soft callus stage, but not so when you're forming a hard callus. So I'll show you a picture of this. So I'm not sure what bone this is supposed to be, but it's a simple break as far as it's complete, but it's just in 2 pieces. And you can see that blood vessels were broken along the length here, and a hematoma formed at the site of the break. The next thing that happens is that fibrocartilage as well as collagen is laid down in that location, brought in, those cells are brought in through the bloodstream. And then this callus, which is happening across as well as on the sides, becomes a hard callus. And usually the transverse portion is going to be composed of spongy bone. It's laid down in trabeculae or spicules. Usually the outside looks a little bit more like compact bone right away, but eventually, the last step here, bone remodeling is going to happen, where osteoclasts break up the spongy bone and osteoblasts lay down nice compact bone. This takes 3 to 4 months. You could probably walk on it during that time. And so this bone remodeling will restore the marrow cavity, and it will harden the compact bone on the outside, make it more dense. Okay, let's do some review questions here. Name the type of fracture that you see in A, B, C, D, E, and F. And I'll go through the answers with you. This is an open fracture, right, or compound. The rest are all closed because you don't see any peeking through the skin. This one you could call a fibula fracture, but it's labeled as closed. This one is an incomplete fracture. Here's a complete fracture. This one is also complete, but because of the angle, it's been named oblique. And then here's an example of a comminuted fracture, where there's more than just 2 pieces. Okay, let's do some review questions here. Do you think it's true or false here? A fracture in the diaphysis of a long bone often results in premature arrest of bone elongation, and I should have said in children. So in the diaphysis, is that where the growth in length occurs? Nope, that's not where it occurs. So this would be false. If I change this to epiphyseal line, then it might be true. I don't know about often, but much more common. And then number 3 says a green stick fracture is an example of a comminuted fracture. Is that true or false? And that's false because you don't even have a complete break. So the answers are also posted here. And then unfortunately the answers are already here, but you should be able to place in order the steps of bone healing after a fracture. So the first thing is a hematoma, then a soft callus, then a hard callus, and then remodeling. Okay, so now we're going to go on to the second topic, and this relates to how bone participates in calcium blood levels. It also participates in pH balance and phosphate levels in the blood, but we really want to focus on calcium because it is the most tightly regulated, much more tightly regulated than phosphate. So our blood level of calcium is between 9.2 and 10.4 milligrams per deciliter. And that calcium is used for many different things. That's why it's pumped throughout the body. It's used for muscle contraction. It's used for exocytosis. It's used for exocytosis of neurotransmitter. The neurons have to have calcium on the outside of the cell be transferred to the inside of the cell in order for neurotransmitter to be released and the secretory vesicles to fuse. Then we also need calcium because it's part of the resting membrane potential. Now, it isn't one of the major players like potassium and sodium, but just the presence of calcium in the extracellular fluid, in the extracellular fluid, it gives a certain balance of cations and anions so that the sodium and the potassium that are going to move across the cell actually make a difference. It's also required for blood clotting. So some of the steps in forming a clot need calcium as kind of a cofactor. Okay, so blood pH is also tightly regulated, and it's regulated at 7.35 to 7.45 pH in a very tight range, and that's needed for proper enzyme function. It's also needed for balancing the pH of other fluids in your body. It's good to have the blood maintain something constant so that hydrogen ions or bases can be exchanged with other fluids in your body. And this is performed largely by the bone storing bases. So if the bone releases a base, this pH would go up. We'll come back to that. And then our phosphate in the blood is kept within 2.5 to 4.5 milligrams per deciliter. And it's needed when cells make DNA, phospholipids, organelle membranes, and proteins. So we're going to focus just on blood calcium and what happens when there's imbalances, as well as how it's regulated. So calcium is transported in the blood either freely suspended or bound to some proteins, kind of both. It is an ion, so it can easily dissolve in the plasma, but sometimes it's bound to proteins anyway. So when hypocalcemia occurs, that means that the blood has too little calcium, less than normal, below 9.2 milligrams per deciliter. Okay. Now, strangely enough, if you had low calcium, you would think you would not be able to form muscle contraction. But instead what happens is you get this muscle tetany. You get an involuntary spasmodic contractions. And that has to do with the fact that calcium levels are so low that calcium stays within a muscle cell rather than being in the cytoplasm, rather than being stored back into the sarcoplasmic reticulum. And so you have continuous and uncontrolled, unregulated muscle contraction. In addition, you have excitability of the nervous system when you have low calcium. And that's partly because the outside of neurons will see less calcium, so the outside will be more negative than usual. Normally we see a large positive overall charge on the outside of cells, but if you have low calcium, that changes things. Hypercalcemia, by contrast, is high levels of calcium above 10.4 milligrams per deciliter, and this depresses the nervous system and weakens muscle contraction. And part of that has to do with the same factors. If this is a muscle cell that has calcium stored in the sarcoplasmic reticulum, I'm trying to draw the sarcoplasmic reticulum. Okay. And you have excess calcium out here, right there. Most of the time, the calcium doesn't release as easily to cause the muscle contraction inside the muscle cell. And like I talked about with the nervous system before, if you have a lot of calcium on the outside of a cell is very, very positive, and that disrupts the sodium gradient, the sodium electrical gradient. So you might not get as much sodium on the outside, and it would be hard to excite the nervous system. Those details are not something you'd ever have to explain, but you should know that hypocalcemia means low blood calcium, and it causes the nervous system to be excited and the muscular system to have spasmodic contractions. You should also know that hypercalcemia means an increase in calcium, but in contrast, it depresses the nervous system and weakens muscle contraction. Okay, now let's talk about how this blood calcium is regulated by bone. How that happens is through bone remodeling. So we have bone and blood. Both of them have calcium. Okay, so the bone matrix through mineralization has calcium, and the blood has calcium. When the blood calcium level gets low, let's say it gets low, the matrix can be reabsorbed by osteoclasts. And so the matrix is reabsorbed and calcium is released into the bloodstream. In the opposite way, we can lower blood calcium if it's too high. If blood calcium is too high, then the bone can deposit that calcium into the matrix, and that happens by osteoblasts. Now these are the components of the matrix where you find calcium. Hydroxyapatite and calcium carbonate both contain calcium. So that's where the calcium would be put. Notice that if we break down calcium carbonate or we break down the hydroxyapatite, you will have other things released, not just calcium, like phosphate, a hydroxyl group, a carbonate group. These are all bases. These are bases. So if osteoclasts break down bone matrix so that calcium gets into the blood, so do these bases. The bases get into the blood. And so these bases will increase pH. If we go the other way, then we lower pH. But you won't be asked about pH, okay, on a test. So just to review, there's calcium in the blood, there's calcium in the bone. Osteoblasts can deposit that calcium into bone, and osteoclasts can break down that matrix and release the calcium into the blood. Now there are hormones involved that regulate the activity of bone resorption and deposition, and there's 3 of them. 2 of them raise blood calcium and only 1 lowers blood calcium. The 2 that raise are parathyroid hormone and calcitriol, which you probably know of as vitamin D. So parathyroid hormone is a peptide hormone. It's made by the parathyroid glands that sit behind the thyroid, and it acts to raise blood calcium. So in some way it's going to cause bone resorption in some fashion. At least that's an option if we're thinking about just bones. There are other things it can do too. Calcitriol, notice the OL, is a steroid hormone. It's the active form of vitamin D, and it's made through a complex process with a lot of precursors by the skin, the liver, and the kidneys, and it acts to raise blood calcium, and it can also resorb matrix. Now the only hormone that actually lowers blood calcium is calcitonin. And I remember this, I know there's 3, right? And I find calcitriol and calcitonin a little confusing. So I just think tone down calcium. And that means in the blood. Tone down is my little clue. So calcitonin lowers blood calcium. It tones blood calcium down. It's a peptide hormone, and it's produced by the thyroid gland. So overall, to raise blood calcium, we want to do bone resorption, and these are 2 hormones that would be involved, parathyroid hormone and calcitriol. And to lower blood calcium, we would need to deposit matrix. That would take calcium out of the blood and put it into the bone, and there's 1 hormone that does that, calcitonin. So here's another summary. For bone deposition, osteoblasts do that, and calcitonin probably stimulates the osteoblasts. For bone resorption, osteoclasts perform that, and these are the hormones that would facilitate that activity, calcitriol and parathyroid hormone. So we're going to look at each hormone individually. Here's parathyroid hormone. Its overall effect is to raise blood calcium. Here are the parathyroid glands, these little yellow circles. And in order to raise blood calcium, it stimulates osteoclasts, but it also inhibits osteoblasts. So it changes the balance of the normal bone remodeling that's happening, making more clasts active and less blasts. But there's more that it can do. Parathyroid hormone also reduces how much calcium the kidney gets rid of, and it also promotes vitamin D synthesis. And vitamin D synthesis, you might remember, needs to happen in the skin, the liver, and the kidney. So we're going to look at calcitriol next. So calcitriol, the overall effect, again, just like parathyroid hormone, is to raise blood calcium. And it can do it in a similar way, that is, acting directly on bone cells, the osteoclasts, to resorb, do bone resorption, resorb matrix, and release the calcium to the blood. It also acts on the kidney and makes the kidney retain calcium, not excrete it with the urine. But I think one of its most powerful effects, and the reason we put it in our milk, and vitamin D is talked about that we need it so much, is that it helps us absorb dietary calcium by acting on the intestine. So here's the intestine down here. So any calcium intake will be absorbed and it won't be excreted with the feces. So let's look at how calcitriol is made, because you've also heard probably that you need sunlight to make vitamin D. And it's true, you do. In your skin, there is a precursor to this chemical called cholecalciferol. But UV light converts the precursor to cholecalciferol. Now that's floating around in the blood. Okay, so it's released into the blood. It makes its way to liver cells, and liver cells modify cholecalciferol and make it calcidiol. It goes to the blood, released to the blood, and then it goes to the kidney cells in the bloodstream. And certain kidney cells can finalize the production and make it the active form called calcitriol. So calcitriol and vitamin D we kind of think of as synonymous, even though all of these are precursors to vitamin D. So here's a picture. UV light penetrates the skin to make a precursor or change a precursor. Then the liver changes by adding an OH to calcidiol. And then the kidney adds a hydroxyl group and you get calcitriol. So now you can do bone resorption and absorb all your dietary calcium. The last hormone is called calcitonin, and remember that's going to lower blood calcium, tone it down. It's produced by the thyroid gland, and there are specific cells right here called C cells or parafollicular cells. I know your textbooks talk about the fact that calcitonin doesn't really seem to play a big role, but it's that statement is contradicted in other textbooks, so I thought I would just go ahead and teach it anyway, because we know it happens in other animals for sure. So in response to high calcium, hypercalcemia, these cells will produce calcitonin. And so the calcitonin goes into the blood, arrives to bone tissue, and it inhibits osteoclasts so that more matrix is not broken up or resorbed, and instead stimulates osteoblasts, taking calcium, which take calcium from the blood, and deposit it into the bone. So that's how calcitonin works. There are many other hormones that do play a role in regulating calcium because they regulate bone growth and remodeling. Estrogen, for example, promotes bone deposition. Testosterone does, insulin does, and You've probably heard of elderly women that aren't making estrogen anymore. Their bones weaken, and that's because they're not performing as much bone deposition. Whoops. If low. Okay, and then cortisol is a stress hormone produced by the adrenal gland, and it promotes bone resorption. It also causes an imbalance in bone remodeling. It takes the calcium out of the matrix. And then there's growth hormone and thyroid hormone that really don't deal with bone remodeling, so not about blood calcium levels. Instead, they stimulate the proliferation or mitosis of chondrocytes, so it helps bones grow in length typically. So let's do some review questions. Osteoblast functions include what? Bone deposition, bone resorption, blood pH would increase, blood pH would decrease. So we know bone deposition is true, right? And when that happens, bases are put into the bone as well. So that would make the hydrogen level go up, but the pH would go down. It would become more acidic. I won't ask that on a test though. Which hormones made by the skin? And that's just this one, calcitriol. Which hormones stimulate bone deposition? That's calcitriol. Oops, sorry. Bone deposition's wrong. Calcitonin is the big one. I have to check that. I messed up. Yeah, no, that's right. Good. Woo. Okay, and number 4, which gland produces a hormone that activates osteoclasts? And that should be, which one? Parathyroid hormone. The thyroid gland has C cells that make calcitonin. And then this last question here, calcitriol or vitamin D promotes bone resorption. Okay, so taking calcium out of the bone. It does do that. Why then do we claim that it's helpful for bone health? Well, it has to do with the intestinal absorption of calcium and acting on the kidney to not allow calcium to be released with urine. There's the answers. Okay, so osteoporosis is our third topic. We've got 2 more topics. And osteoporosis is related to our previous discussion of hormones because it often happens in elderly women who have decreased estrogen production. If they have decreased estrogen production, then osteoclasts are more active than osteoblasts. So I'm going to go back up here. So what osteoporosis is a severe loss of bone density, and you can see that there aren't nearly as many trabeculae or not as much spongy bone. This is the body of a thoracic vertebra, and so the bone is brittle. It's more easily fractured. Spongy bone is always affected first, and then the compact bone, which would be on the outside, would be affected secondarily. So we know that for this to occur, this osteoporosis, the osteoclasts had to be a lot more active than the osteoblasts. Okay. So men throughout their lifetime, believe it or not, make enough estrogen, and that's come from their adrenal gland, which we haven't really talked about, but men also make estrogen. Women do too, but most of their estrogen comes from the ovaries. But in addition, men make testosterone through the testes, and that's continually throughout their life. That usually is enough to maintain bone density, enough osteoblast activity. But in women, this loss of estrogen, it decreases osteoblast activity, and so there are various treatments. One is to try to inhibit the osteoclasts, and that happens with certain drugs. Try just to inhibit those. So now things will be more balanced. The other thing that can be done is to try to bring up the activity of osteoblasts, and that would be done by replacing the estrogen. Now there are a number of things that can be done to prevent this problem, at least maybe not get rid of it completely, but lessen the degree. And so that would be things like weight-bearing exercise, which stimulates bone deposition, eating enough calcium, and of course getting enough vitamin D so that you absorb that calcium. So weight-bearing exercise stimulates osteoblasts. Now they're stimulated through osteocytes, not clasts, osteocytes that just, we remember they're just trapped in their lacuna. They're just sitting in here. We thought they weren't doing anything, but they can actually signal osteoblasts to start depositing bone. There's another type of soft bone or bone weakening called Osteomalacia. So in this case, there's impaired mineralization. The osteoblasts might be working to secrete soft osteoid, but there isn't enough bone minerals or enough minerals in the blood for the osteoblasts to work in causing mineralization. So it's called bone softening, softening of the bones. And this disease was discovered first in children and named Rickets. So they noticed that children were developing these abnormal bone formations, and it was due to softening of the bones. And the reason that these deformities happen is because they're putting weight on soft bones which are flexible, and so according to the line of stress, the bones will bend. And then if their diet improves or mineralization increases, these bones just form as hard bones with hard matrix in this formation. So the causes of osteomalacia, which we typically think of as in adults, and rickets we think of as in children, is that they have a diet deficient in calcium or vitamin D. It could be due to limited sunlight exposure or liver or kidney disease if you can't make vitamin D. There are also genetic, etiologies of this disease, and that would be that the vitamin D receptor is defective, like there's a mutation. So maybe there is enough vitamin D available, but it can't function because the receptor's not working. So you'd have not enough calcium absorption from the intestine. So the treatment is typically to increase calcium intake and vitamin D, either by exposing to sunlight or by taking in orally vitamin D. Now if you have a genetic defect with the vitamin D receptor, I do not know how they treat that. I don't know if you can do gene therapy or not. Okay, our last topic is on arthritis, and I threw in a couple of other types of inflammatory conditions related to joints, because I wanted you to see that this itis, arthritis, bursitis, tendonitis, itis means inflammation. So for arthritis, inflammation happens within a joint. Arthro is joint. Bursitis, inflammation happens within a bursa. And I have this written down over here. Tendonitis happens so that there's inflammation in the tendon. So the difference in all of these is just based on what structure is inflamed. So remember that the joint capsule inside here, this is the outer coating of the joint capsule, this is where inflammation would happen for arthritis. In terms of bursitis, we've got several green bursa here. There's one over here. I think the one that commonly gets inflamed is this one and this one. Certain workers that bend on their kneel on their knees a lot, they'll have bursitis. And then tendonitis would be in a tendon, a muscle tendon, inflammation there. Now, what is inflammation? Well, it's swelling, redness, heat, and pain. Those are the 4 cardinal signs of inflammation. Now, long-term inflammation also might cause permanent deterioration of tissue, loss of tissue, and therefore loss of function. It depends on what the cause is and what type of inflammation you're talking about. So for bursitis, usually the cause of bursitis is friction or some sort of a trauma. And if you just, stop doing that particular activity and let the inflammation calm down, there's no loss of function. Tendonitis is usually the same. It's usually due to overuse of a muscle, and so the tendon is moving as the muscle contracts, and overuse of that muscle puts extra friction on the tendon. So if you stop performing that action for a while, the tendonitis should subside. Now, of course, inflammation can always happen due to infection, okay, because something foreign has entered at that location. Then you would treat with antibiotics, of course. Now, arthritis is within a joint capsule, and typically we think of arthritis as sort of a wear and tear, like friction sort of thing. But there's really different types. So there's 4 main causes, one of which is wear and tear. So I'm going to look at the 4 types of arthritis, inflammation in a joint capsule, and their causes. So the one that's wear and tear we call osteoarthritis. Now, just because I say wear and tear, it doesn't mean that there can't be underlying factors that make it more likely somebody's going to get arthritis in their knees or in their fingers or whatever. There seems to be a genetic component, so that in families we see a tendency more towards getting arthritis versus not, even just with routine use of a joint. And then there's rheumatoid arthritis. That definitely has a genetic component. It's an autoimmune disorder. So what happens is antibodies actually attack joint tissues. Then there's gout, which is a type of arthritis that's actually a metabolic disorder. It's not due to wear or use or anything like that. And then there's Lyme disease, which is caused by a bacterial infection. So we're going to look at the pathology of each one of these. A little bit about osteoarthritis first. We usually do call it the wear and tear kind of arthritis. So age and impact injuries and overuse all contribute to osteoarthritis. But there could be a genetic defect because one of the components of bone as well as cartilage is collagen. And if someone has a defect in a collagen gene, then those tissues would not be as strong and be more prone to normal wear and tear, causing destruction of joint tissue. So typically the way the disease occurs is that articular cartilage degenerates. And so then you just have bone on bone. So if you think of two bones that articulate, and there's hyaline cartilage up here, and there's hyaline cartilage down here, that's supposed to provide, a little bit of protection to the bone, makes the two bones glide smoothly past one another. If that articular cartilage has degenerated, then you just have bone on bone. And that's kind of grating, right? And it would cause the bone, it would cause damage to the bone. That activates, that kind of damage activates inflammatory cells in your immune system. And those cells send out signals to the bone. Hey, you're being worn down, you need to start, fixing yourself, adding more bone. So bone deposition will happen in response to this mechanical stress. The problem is the bone deposition does not happen in a nice orderly form. Spurs form, and these spurs are in locations that cause pain when you move the joint. And often you'll hear a crunching sound when somebody moves the joint. That's called crepitus. So here's an example of what happens when the body tries to correct osteoarthritis. So this particular joint is normal. Okay, this is a normal joint, knee joint. You've got articular cartilage here. They haven't drawn the articular cartilage down here, but you also have that. In addition, you have these soft pads, meniscus, fibrocartilage. What happens if over time the hyaline cartilage wears down and the meniscus wears down? Well, then bone on bone happens. So here's some cartilage loss. You see the bone peeking through. And the joint space narrows because the meniscus isn't in place anymore, and because the bone has been signaled to grow, to repair. And so it grows to the extent that it it decreases the space in the joint capsule. And notice all the bone spurs that happen. Okay, so it's not a nice regular healing at all. Okay, rheumatoid arthritis, as I mentioned, is caused by antibodies. So it's an self-reactive sort of thing, an autoimmune disease. They typically attack the synovial membrane. So the synovial membrane in the joint is broken down, and now inflammatory cells have access. They are activated, and they send out signals to the synovial membrane, which is part epithelial tissue, remember, to proliferate by mitosis. So you get hypertrophy of that membrane. And then if you have more membrane, you have more fluid buildup. So the joint becomes swollen. Now, some of those inflammatory cells that have been activated are also macrophages, and they will come in and try to clean up any debris. When they do that, they aren't very regulated. They could degrade some bone or some articular cartilage, not just broken debris. So the symptoms are swelling. Inflammation, I guess you think of as swelling, but inflammation also includes dilation of blood vessels to get more of those repair cells to the site of damage. That's the intent of the body anyway, but with it comes all these harmful antibodies and macrophages. But with the vasodilation, you have more heat, more swelling, and more pain. Then the bone deposition could occur to correct for degeneration. And so, like we saw before in osteoarthritis, you get more bone deposition in the joint capsule, but it happens to such a degree in rheumatoid arthritis that you could end up with complete ossification and immobility of the joint. So this picture right here, the one with all the detail, is to show you that the joint capsule, the synovial membrane here, has been impaired in some fashion. And signals have been sent out to blood vessels to dilate. And so this blood vessel has dilated, and all these inflammatory cells or immune cells come in. Now originally it was antibodies that destroyed this synovial membrane. But now we have all these other immune cells here. Some of them send out signals that cause the remaining synovial membrane to grow. So it grows and it produces more fluid. The more fluid it produces, the more immobile the joint is because it swells. And there's also signals that are sent out to the bone to start increasing the number of osteocytes. And so, I mean, it's a fascinating disease. And so eventually you could get complete ossification across that synovial joint. And this is a picture of something that's typically seen in advanced RA in someone's fingers. So these knuckles are typically immobile. Now, gout's kind of an interesting cause of arthritis. The reason it happens is because there's an increased blood concentration of something called uric acid. Now, normally the kidneys get rid of uric acid. It's a normal byproduct of breaking down things that we eat that have nucleic acids. So nucleic acids are just DNA in a nucleus, but we eat lots of nuclei. So uric acid's a normal byproduct of breaking those down, and the kidneys usually get rid of it. In this case, uric acid that's floating around in the blood and does not get filtered out by the kidneys deposits in joints as crystals. Now, uric acid will form crystals. It even can form crystals within the kidneys. But for some reason, this disease, gout, the crystals form in, often, the first joint you see it in, is here between the first metatarsal and the first phalange in the foot. So these crystals form here. Now those crystals are not supposed to be there, right? So that activates all sorts of signals, causing blood vessels to dilate, recruiting inflammatory cells. So you get heat, pain, swelling. And the articular cartilage and synovial membrane will be broken down, and eventually you'll have ossification of the joint again, just like before in RA. They don't exactly know why this happens, but they're doing some research, and they have found some problems in the kidney with getting rid of uric acid. In the kidney there are these proteins called renal transporters. So this is the urine, this is the kidney cell, and you could think of this as the blood if you want. So if you have uric acid buildup in the blood, normally the kidney would take it and move it towards the urine, and you'd get rid of it. And there are many different proteins that help transport that uric acid in towards the urine. And I circled 3 of them. Maybe that one too, GLUT9. Yeah. But anyway, these they're finding genetic defects in people that have gout. So they're working on it. The last form of arthritis is Lyme disease, and this is due to a bacterial infection in the blood. The bacteria is Borrelia burgdorferi, and all vertebrates can host this bacteria. But the way that transmission typically happens is that there's a vertebrate that's not terribly affected by the presence of this bacteria. So the vertebrate serves as a host or a reservoir of the bacteria. they're probably not harmed by it. But let's say, I don't know, it's, a wolf or a deer or whatever. Then ticks bite that vertebrate out in the woods, and when they bite into the bloodstream, the bacteria are there, so the ticks acquire the bacteria, and now the ticks move off. They go to another host, could be a human. They come and they bite a human, and when they bite, some of the bacteria are still present in the biting apparatus of the tick. I don't want to call them teeth because they're not really teeth, and so in that case the bacteria are transferred to the human during the tick bite. So the bacteria causes problems in the human, whereas it might not have done so in the original vertebrate host. What happens in the human is that antibodies specific for that bacteria start forming. Your immune system is reacting to the presence of Borrelia burgdorferi, and your B lymphocytes make antibodies in response. So this is usually the test. They test your blood for antibodies to burgdorferi. However, it turns out this isn't the best or only way to test to see if somebody has this bacteria. It's kind of a controversial subject, but this is what they still use. And then what they treat with is antibiotic. And this antibiotic should kill the bacteria dead. What you see in somebody who has Lyme disease is the site of the tick bite, which was right here, develops kind of what we call a bullseye rash. But sometimes if it's on the back of your neck, you wouldn't see that. It does dissipate after a couple of days, so you don't always see that. But you do get inflammatory reaction that's pretty widespread in your body. The initial onset of symptoms starts with chills and a fever and a headache and muscle pain, a little bit like the flu. But then later you get itching, joint inflammation, pain, and often a stiff neck. Even if the bite occurred on an appendage, you usually get a stiff neck. I don't know if the bacteria like to go there or what. So that's Lyme disease. Let's just look at a few review questions that will kind of summarize all the different disorders we talked about. Can you name a brittle bone disease that's caused by a lack of a hormone which would normally stimulate osteoblasts? Osteoporosis. And then number 2, name a disease that's caused by low calcium in the blood, hypocalcemia, or vitamin D deficiency that results in soft bones. Well, there was 2 of them, Osteomalacia and Rickets. Rickets in children. Then you should be able to name 4 types of arthritis: osteoarthritis, rheumatoid arthritis, gout, and Lyme disease. But which of those is due to a metabolic product crystallizing in a joint? And that would be gout. And which type is the most common? Osteoarthritis. Oops, that's supposed to be an A. Osteoarthritis. And 6, which type of arthritis could cause immobility of the joint? Well, we typically think of RA for that. But truthfully, if things are severe enough, so could osteoarthritis. You could get immobility, and you could with gout as well. It depends on how long it's progressed without any kind of treatment. And then number 7 asks you, how is Lyme disease spread from vertebrate host to vertebrate host? And that's through tick bites. And the ticks have bacteria. So that's the end of the lecture and the end of the skeletal system physiology that we will cover. Thank you.